as Reshma had pointed out, hyperglycemia has been a big issue in terms of tolerability of the PI3K agents. In the studies that had evaluated alpelisib, the cutoff had to be more stringent as we enrolled patients on those studies, with the hemoglobin A1C actually less than 6% for eligibility. Because of the lower rates of expected hyperglycemia with our AKT inhibitor, Capivasertib, the CAPItello-291 study, which evaluated the efficacy of Capivasertib with fulvestrant, allowed for patients up to have a hemoglobin A1C up to 8%, so had to have less than 8% hemoglobin A1C. And when I think about the lines of therapy for patients with metastatic hormone-positive, HER2-negative breast cancer, in my head as I'm sitting with that patient in front of me, I am thinking through, okay, we're going to start with our CDK4/6 inhibitor endocrine therapy. I'm going to get biomarkers at time of progression, or perhaps earlier than that based off of SERENA-6. If they do have a PI3K mutation that I've already identified at baseline or at time of progression, I'm thinking through the tolerability and toxicity of our AKT inhibitor, Capivasertib, and thinking through particularly the hyperglycemia. So if I see that a patient at baseline has a PI3K mutation, I oftentimes will get a hemoglobin A1C to assess, and if they are borderline pre-diabetic or perhaps they're newly diabetic, that is a patient who I'm oftentimes consulting with our endocrinology partners to determine if we can help with dietary changes, exercise modification, perhaps anti-hyperglycemics, an earlier start to that, so that at the time that we need to switch to a PI3K or AKT inhibitor, that patient is in a better place for tolerability purposes.
I love that because we have certainly seen that even if you are within the hemoglobin A1C eligibility range, the higher your baseline A1C is, the higher the risk of developing hyperglycemia. And you know, we've published a case, well, more than a case series, a cohort study which looked at off-protocol use predominantly of PI3 kinase inhibitors. And the two major risk factors for hyperglycemia, as you might expect, right, were body mass index elevation as well as a higher baseline level of hemoglobin A1C. So I like that strategy of using that upfront time, maybe while the patient is on first-line therapy, to prepare their glycemic status for AKT or PI3 kinase inhibition. And Reshma, you brought up using metformin, and you know, I think prophylactic metformin is something that we often do consider. Are you using it for all of your patients, and when do you start it? I'm assuming prior or with the AKT inhibitor, with Capivasertib. What's your strategy?
My typical strategy has been for patients that do meet that pre-diabetes threshold of a hemoglobin A1C of over 5.7, but lower than the diabetes cutoff. I would consider starting it. In those with a BMI over 30, I would consider starting it. But to Manali's point, I think now that we are increasingly using a biomarker-directed approach for the second-line setting, we do have that window of opportunity to optimize glycemic control. And I think our patients are actually very motivated knowing that we are thinking ahead for them. And it's been a useful strategy to get the dietitian involved, engage with our endocrinology partners, and you know, optimize their glycemic control before going into this very effective treatment strategy.